Ladies and gentlemen, could you please welcome to the stage your chair, Anita Anand.
Hello, good afternoon. I hope you had a good lunch. I hope you had a very productive afternoon. Judging by the programme, you have come away with a lot to think about. I don't know how many of you, there was that sort of rather hilarious mass exodus following Jeremy Hunt. But if you did stay in the hall, you would have heard from Patrick Souchon, who was talking about some rather stunning innovations in medicine that he is currently working in. And really innovation and technology and new ways of doing things, that's what this next session is all about. So let me tell you a little bit about how it's all going to work. We have 4 excellent speakers here who are going to be telling you their idea of how things can be done differently in an innovative way. They come from very different walks of life, and then we're going to be taking some questions from you on the floor. So please put your hands together and welcome our outstanding panel today. Let me make sure I say them in the right order, because we have with us, well, you'll remember from last year, Paul Scandrett is here, Director of Healthcare Allocate Software, and he's going to be, I think, talking about workforce, aren't you, and innovations that can be done in the context of new care models. We also have Noreen O'Neill, who is a patient advocate with a very compelling personal story. It's been a real journey for Noreen, from being a patient to a patient advocate. Nikki Ronicles is with us, Commercial Director of Big White Wall. That is a big white mystery at the moment, but she will clear it all up. And then with an overview of what NHS England is doing and how it's reacting to the new technologies that are out there, we're very lucky to have Beverly Bryant, who's Director of Digital Technology for NHS England. Please put your hands together and welcome our panel. So let us first call to the stand with his idea of the brave new world that faces the NHS, Paul Scandrett.
Thank you, Anita. It's a pleasure to be on stage today with 4 lovely ladies. I now know what Boswell feels like in Charlie's Angels. I've been working with technology in workforce for the last 20 or so years. Having started when I was 10. And during that time, I've worked in very different markets, everything from the military to cruise lines. 10 years ago, I started working with the NHS. My wife, who prefers to be known as Dr. Spencer and not Mrs. Scandrett, told me working with the NHS would be like nothing I'd ever done before. And she was right. I have worked with and met some amazing people who share Alison's commitment. The big difference, though, between the NHS when it came to the workforce and deployment that I saw across other markets was that every other market I'd worked in, it was very focused on activity versus the workforce. How much activity are we going to deliver, and therefore what is the workforce that we need? That was very rare. In fact, it was very rare up until last year, post Francis and the NICE guidelines, when for the first time people started talking activity when they spoke about the workforce. In fact, 12 months ago I was talking about safe staffing on this very stage. 12 months forward, and as has happened in the NHS, the pendulum has swung towards cost and the reduction of agency expenditure. Changing agency rates is fundamentally important. It's necessary, but doesn't mean everything. We have to use other tools that are in our kit bag as well. At a fundamental level, we can reduce agency expenditure by having fewer requests, and the requests that we do have being fulfilled by our substantive workforce. There's a couple of ways that we can think about doing that. We did some research recently as part of our Insight program, which said that of nurse rostering, when staff are rostered above establishment levels, 37% of the time, it is not due to clinical demand. In fact, it's due to the workforce and when they can and can't work. So that alignment with activity needs to be brought front and center, regardless of what emerges in terms of the NICE guidelines going forward. Organizations do that. Typically, in my experience, in the US where we work, those systems are absolutely aligned between rostering and what the clinical systems are. Every day, every shift, every hour, that alignment is being looked at. Why is that? Because it delivers the best quality care and it delivers at the right cost. When it comes to the occasion when you do need to use temporary staff, I think that's where technology is and can make a big difference. I think one of the things I've learned about technology in the NHS, whilst it might be about tomorrow's world, there are some very practical solutions that can be implemented today. The great thing about most 24/7 operations is that rosters are put together 4 weeks before they go live. That gives us a 4 to 8 week window to know what's happening. The first finance director I ever spoke to said, what is it you're trying to sell me? I said, it's a rostering system. He said, well, listen, son, whatever you do, don't show me any graphs, because I've got a lot of graphs at the moment, but they're of no use. I said, why is that, Keith? And he said, well, because they only tell me what's happened, not what's going to happen. And that's the absolute opportunity that we have. Many of our customers now publish all of their bank shifts up to 8 weeks before they happen. Using mobile technology, employees, substantive staff can then see those shifts at any point, whether they're having a coffee at home or in Costa. They can decide what shifts they want to work. Some of our customers now have 65 to 70% of those shifts being self-fulfilled. What does that mean? Your fill rate goes up, the staff are happier because they work in when they want to work, and guess what? You end up spending less on agency. In the US, this process has been in place for many years. In fact, they've taken it a step further. They have a concept that they call shift bidding. The way that shift bidding works is if there's a really popular shift, staff will say, I want to work that shift, and in fact, I'll work that shift at a lower cost. We are, of course, some way away from being able to do that in the NHS. Where there is the opportunity, though, and I think this is a big one, especially for those hospitals in large cities, is why don't they share their banks? Now, because of the shortage at the moment, there's a real reticence to do that. However, the reality will be one trust will be using agency when the trust down the road might have spare bank. The technology exists to make that mobile today. So to finish off, I think the key message is, yes, technology is an enabler, and getting ahead of the game in terms of knowing what's coming down the pipeline is absolutely key against your activity. There is, of course, though, the reputation of technology in the NHS, and they have not always been good bedfellows. The thing that I've learned is you have to bring the staff with you. The front line have to be part of the process. And that's a terrible cliche, but no more important when you're implementing technology, because you will be asking them to change via that technology. And I'll leave you with this one thought, which is, before you break down some of those walls, it's probably a good idea to ask the front line why they were put up in the first place. Thank you.
Paul, thank you very much indeed. One thing that I forgot to mention, unforgivably, is that, again, as with all of our sessions, you can go online, nhsconfederation.org, and the interactive site that we've set up for you, because I know some of you, I don't know why, they're nice people. I've met them. The paddle people, though, intimidate some of you. So if you do want to ask a question of any of our panelists on any of our sessions, just go to that place and you can post your question or your thoughts or your comments there, and we will attempt to read them. And it's really important to talk about that way of communicating, particularly in view of who's speaking next, because it is all about digital communication and how helpful it can be in well, the world of treatment of patients as well. Please welcome to the stage Noreen O'Neill.
Thank you for inviting me here today. My name is Noreen O'Neill, and I'm an expert patient from Northern Ireland. 15 years ago, I lost my eldest brother, Niall, a doctor, to suicide. 10 years ago, I was diagnosed with acute promyelocytic leukemia, a rare form of leukemia that affects 1 in a million people in Europe. I received 4 sessions of chemotherapy between Cardiff University Hospital and Belfast City Hospital, and I'm now as good as cured. 3 years ago, I had a beautiful baby girl. Dr. Atul Gawande said, "If no one notices excellence and no one cares, we will have a demotivated healthcare staff." And so today, I wish to celebrate the excellence of the NHS and thank all of you for saving my life. Auden Utengan, a healthcare consultant with Simpler, said, "The world is changing, boundaries are being broken down, and Twitter is a new melting pot of people, ideas, and disruptive innovation." And we all know that healthcare is an extreme disruption at the moment. But I love Twitter. Twitter has a diverse community of healthcare professionals, patients, academics, businesses, organisations, and charities. In fact, it was on Twitter that I became aware of the words of Leonard Kish. If patient engagement were a drug, it would be the blockbuster drug of the century. And so technology enables patient engagement, and technology empowers all of us to make meaningful changes in our lives. But the word patient is no longer enough. We now need to think of patients in terms of e-patients, lay patients, expert patients, patient journalists, and patient ambassadors. We need to move from what Dr. Larry Chu said, from the paternalistic model of medicine to a more participatory model of medicine. So how do we do that as patients? Well, as a result of my involvement in healthcare social media, I followed the EUPATI annual conference in Warsaw last year remotely from Twitter. Following that, I won a scholarship to become an expert patient in medicines research and development with EUPATI. EUPATI is the European Union Patients Academy in Therapeutic Innovation, and we have to spend 170 hours e-learning the medicines research and development process and 10 days face-to-face sessions in Barcelona. In addition to this, I was invited by the Dutch Genetic Alliance to join a patient think tank on their Asterix FP7 project on rare diseases and orphan drugs. I also won a scholarship to attend the European Forum on Good Clinical Practice annual conference in Brussels earlier this year. Excuse me. Last year, I ran a tweet chat called Epic Chat. The hashtag was registered with Simpler, and it stood for the emotional and psychological impact of cancer. I did my own marketing for the tweet chat and my own promotional video. I managed to reach over 2 million people globally, and psychologists, psycho-oncologists, psychiatrists, and patients all took part in the tweet chat together. It was an overwhelming success. Dr. Matthew Katz, known as Subatomic Doc on Twitter, said, "New technologies are not the solution. What they are the tools for the patients to empower themselves. But we need more tools. What we need is a virtual health centre with e-consultations, with Skype visits. If we're going to be able to download our medical records, we want to be able to understand them, and therefore we need an e-library, and all of you to show us the way, point us to the links, and validate all the articles and information that is on the internet, because we all know that Google is no longer a reliable source of information. We also need to see healthcare social media and healthcare technology on the school syllabus at an early age. We need to empower our children to become patient advocates at an early stage, and we need to follow this through until third level education. What we need is something like the MedX course that the University of Stanford of Medicine are currently running for their patients. They recruit 35 patients from across the world to train as e-patients and become empowered. Our healthcare professionals are under extreme pressure at present. A lot of them are suffering from burnout and depression. If we all work together and if we all support each other, if you allow us to help and you join us, we can make the healthcare system a better system for all of us. As Stephen Sutton said, the young cancer survivor who passed away a number of years ago, a positive mental attitude leads to positive outcomes. Thank you for inviting me here today. I am very inspired by all of the work that all of you do. Thank you.
Noreen, thank you very much indeed, and it will gratify you to know that Twitter's going a bit bonkers about your speech, so there we are. Let us now hear from Nikki Runnercourse, Commercial Director of Big White Wall, and it's particularly mental health services that you're talking about. Nikki.
Hello, my name's Nikki. I've spent most of my career so far working in mental health services, and the vast majority of that has been in very traditional hospital-based services. For the last 4 years, though, I'm lucky enough to have worked within Big White Wall, which is a digital mental health service. So I'm going to do two things in the next 5 minutes. I'm going to first try and describe to you a little bit about what Big White Wall is and the kind of outcomes it's seeing, and then I'm going to describe to you our vision of tomorrow's world. So first of all, to Big White Wall. 1 in 4 of us is affected by poor mental health, which means every single one of us in this room knows somebody affected. The worst thing, though, is that 75% of people with a diagnosable mental illness do not receive treatment. So that's the problem. That's how traditional services are not working for a significant proportion of people, and that's why Big White Wall exists. It's an entirely online service. It was founded in 2007. It's available now to 28% of the UK adult population through various contracts with military, with health, with education, and with employers. And what it is a 3-tiered system, at the heart of which is an online community, a group of people supporting each other and self-managing their own mental health and well-being. The step up from that are online courses, so you can take an online course on depression or anxiety. And then the step up from that is a platform through which you can have a one-to-one consultation, so for example, a therapy session online through the platform. All of this under the watchful eye of clinicians, our wall guides. So the kind of outcomes that Big White Wall is seeing, 73% of members say that they have disclosed something for the first time ever on Big White Wall because they feel safe and it's an anonymous space. 95% of members have told us they feel better as a result of using it, so have seen at least one well-being gain. And 80% of people say they have self-managed as a result of using Big White Wall. And a health economist has estimated the savings to the wider health economy of £37,000 per 100 members. So that's, in a nutshell, what Big White Wall is. What do we think tomorrow's world will look like? In one sentence, it's a world where the person is at the center of their own care, their own health and well-being, and in control. And I think that's quite an overused statement, so let me describe to you in a little bit more detail what that might look like. It looks like a world where, when I have an illness, a long-term condition, I'm worried about symptoms, I don't feel alone in that. I feel part of a health community rather than on my own. And that any time, anywhere, from any device, I can access trusted information, I can access peers, and I can access professionals. And I can access professionals 24 hours a day, that magic 7 days a week. I don't have to wait. I don't have to wait until I get more ill. A 10-year-old with OCD doesn't have to be told she has to wait 2.5 years for treatment. If I do need to go and see a clinician, I may have that appointment online, I may see them face-to-face, but the important thing is I have choice. I have choice of who that clinician is, of when I see that person, and where I see that person, and I can certainly book that online. In terms of seeing my own health record, I don't just want to see it, I want to own my own health record. I want to be able to input to my health record, and I want to share that with people that I choose to share it with. I have the same data available to me as my clinician has about me. If I have diabetes and I'm using an app to track certain information, it shouldn't be my clinician that sees more information than me. I want to see exactly that same data. It's a world where jargon is stripped out and the evidence around treatment options, alternatives, is accessible to me in plain, simple language. And if I'm happy with the care I've received or if I'm unhappy with the care I've received, I can feed back immediately in real time in a transparent way that I really feel is helping to shape services for both me and other people in the future. So all in all, it's a world where I feel passive and alone, to a world where I feel active and supported. So just to finish on how we might get there, two thoughts to share with you. The first is, most of what I've described there already exists. Organizations such as Big White Wall, Patients Know Best, Mental Health, Patient Opinion, to name but a few. There are lots of others. We need to be better at spotting this innovation and adopting the innovation. And then the last point I would say about the how is quite a difficult one to do, but we need to find a way to give people more control of their own health and well-being. What we see at Big White Wall is that when we do that, people generally make good decisions for themselves. Thank you.
Fascinating. Thank you very much indeed. And that idea of owning your own information, I'm sure, is going to provoke some thoughts among clinicians especially. So please do either think of a question and come to a paddle when we finish, or else just do get in touch with the interactive side. But what is NHS England going to do with all of this stuff? There's all these great ideas that are, and many more besides, out there. Technology moving so very fast, it's almost dizzying. Well, Beverly Bryant, Director of Digital Technology of NHS England, will tell us more.
Good afternoon, everybody. So, it might surprise you to hear that as the Director of Digital Technology, I'm really not here today to talk about technology innovation. What I really want to talk about is cultural innovation. I've got 3 examples of a future NHS that is already happening somewhere today in our NHS. We're already doing it. What we're not doing is spreading it. We aren't realising that the future is already sitting next door to us. The first example is digital medical records, safe electronic record keeping. This is about the NHS joining up to itself. In primary care, we've already achieved 100% of digital medical record keeping. But in secondary care, we've still got a lot of work to do. Paper is passing between wards, discharge summaries passing between hospitals and back to primary care. Where the NHS has done this, the clinicians are owning the process, the transformation, the clinical workflows have been re-engineered to make this work, and it's the difference between good outcomes and bad outcomes, and also good and bad patient experience. People don't want to have to keep telling us over and over again what medicines they're taking, what their allergies are. So the more we can give our clinicians access to the medical record, to the information that's already there, the safer our NHS is going to be. The second example that I want to give is giving patients access to that medical record. We've made great progress over the last year in primary care, with 97% of GPs now offering access to the patient to a summary of their record. It's just a start. It's really important that we bring the medical community with us, and so that's where we've started. Going forward next year, we're going to be moving that forward to the detailed coded medical record. And in the fullness of time, not that far away, if I have my way, patients will be writing into their medical records. The idea is to change the relationship between the GP and the patient so that for example, my sister's a diabetic, and The idea of her being able to take her blood glucose levels or her blood pressure and upload them through wearable devices into the medical record so the GP can keep an eye on her and maybe phone her up or ask her to come in saves the consultation. She's busy. She doesn't want to have to keep going into the GP practice all the time. Other examples of patient owning and working with their own record in secondary care, there's not as much progress, but Hampshire are starting to do it. And in London, the Coordinate My Care project is starting to roll out their patient record to the patients so that people on end-of-life care plans can put in preferences and let them know, let all the carers in the system know what it is that they want to happen in the event that they have an episode. Importantly, it's clinically validated. Patients can change their preferences, but the clinician must sign it off before it becomes the valid record. We're not talking about taking things away from the clinicians. It's about working together with them. And the third example that, again, is happening across the NHS is e-consultations, teleconferences, using telecommunications to stop everybody needing to be within bricks and mortar. We need to save £22 billion. We've heard that every session this last couple of days. And the bricks and mortar, the actual premises, is a large element of the cost. The NHS will always be available for people who need to turn up and be seen and be treated and be operated on. But so much of what we need to talk to our doctors and nurses about can be done within the home. And in the hospitals up and down the land, again, not enough places, we have multidisciplinary teams on teleconference facilities, video consultation and Skype, talking to carers, patients, relatives about the care of the individual. Now, our public are using these technologies in their everyday lives. These are not new, innovative technologies. But culturally, the NHS needs to embrace it because our junior doctors are telling us the shock they have when they come out of medical school to go into work in a hospital to find they have to discard their iPads and start to pick up paper notes. It's not all doom and gloom. We're doing some good stuff. The Nursing Technology Fund and the tech funds over the last few years are starting to really warm up our clinical and managerial community. We've had a bad couple of starts on this, and I know that we've lost a lot of people's faith in how technology can help. But our patients, our public expect it, and so it's time we raised up to the challenge, the transformational change that's required. And I do ask you all to help us to drive forward on that charge. Thank you.
So if you do have a question, please put your hand up straight and proud. And there's one at the front over here. And any more, if you can get a microphone. Just while we are sort of easing into that, you said, you know, we've kind of dipped our toes in the past and it hasn't been all that successful. I mean, the database is one of those things that springs to mind. It seems the NHS and technology, they haven't really got on at all well in the past. What's changed now?
I think where we've gone wrong a number of times. The first time we tried to do it, we threw money at it and we didn't really explain and make sure we had the skills and capabilities back in 2001. And then with the National Programme for IT, I mean, there's a lot to talk about around that, but the main thing for me was that it was trying to solve a problem of joined up technical interoperability across the whole system and solve a system problem. And it didn't stop to think, am I solving the problem of the user, of the person who actually has to use this technology, the doctor and the nurse? So now we're saying, hospitals, organisations, you need to choose the technology that works for you. We want it to have NHS number as primary identifier, and we want it to have open APIs. But we're not going to tell you what to buy and what to implement. You need to own it. And where clinicians own the decisions for the technology, it works.
Let's take the question here. Oh, can we have the microphone on? Because Sam Everington will be heard. There you are.
Sam Everington, GP, Tower Hamlets. I imagine a new world where I'm sitting next to a patient and we're writing a referral together, with the patient's email address, my email address, both our mobile phone numbers, and sending it to the consultant or the team. And the consultant then might ring me and say, I need to discuss the case, or might send back advice, or might ring the patient, or might ring them and say, why don't we book you in for a colonoscopy? That says nothing about booking somebody into outpatients. Is it time we put Choose and Book out to grass?
Me again. So we have, Choose and Book was bought and implemented in 2003, and technology's moved on vastly since then. We are in the process of replacing Choose and Book with a new e-referral system that's scheduled to go live in the next couple of weeks. The reason we've decided to carry on with a national solution, and it's with 45 million live referrals, it's quite difficult to undo that. It's already in a national solution. It's giving people the ability to refer across the country to clinics means that we need that back-end engine, if you like. I always use the example of the IATA database. So in the airline industry, if you want to book a flight, or the BA flight from Heathrow to New York, you can go on lastminute.com, ebookers, ba.com, any front end you want. But to make sure that the customer isn't sat on each other's knee on the same seat, there is a back-end database that makes sure that once that's booked, it's booked. And that's the idea we've got around the replacement for Choose and Book. We allow the clinic slots to be there and made available, and we do need more clinic slots to be made available. But then the GP referrer can buy or have front-end software that actually integrates with the software they're using. And nowadays, with the modern open APIs, that actually is possible. So that's the plan.
Thank you. Any other questions? Number one, over here.
Yep. Hi, I'm Malcolm Gerald. I'm a GP, and I'm sitting on a CCG. I'm going to support Sal Everington here, I'm afraid. We need to be thinking about care planning for patients rather than clinic booking, because I would say half of first appointments in hospital are probably a waste of an appointment. We should be booking them into what they need, not to get somebody else to agree that what we suggest they might need might be a good idea, so that they can then book them in and get it done. And this is a cracking idea, a cracking arena. IT can solve this, and we're not moving at all in that direction yet.
Well, I think that is to you again. Yeah. Yes, it is. Yeah.
We do have some examples where care planning is done in an electronic way, where, and again, London is leading the way actually in that, but Hampshire are also doing it, where the care plan is consulted on across a multidisciplinary team, held at once electronically. The clinicians in charge of the care can add to it and contribute to it, but the version control means that both the patient and all the clinicians know that that is the latest version. I mean, that is the vision. Where we do need to refer, we need an electronic, easy way to do it, including allowing secondary care consultants to onward refer sort of any-to-any functionality, which at the moment isn't available under Choose and Book. So, again, we're not good at selling where it is happening. So I think I need to take that on board and make sure that we just tell some of these stories a little bit better.
I know there is the temptation just to put Beverly on the spot, but actually there's some really interesting stuff that's come up with our other panelists as well, and you two have something in common, which is this creating communities online and how very important that is. Some may say, though, that there is a danger in that people feel themselves to be looked after, and caught in a world that is virtual, that doesn't exist, and that actually when they get to crisis point, in either one of your examples, they may fall, and they may fall hard. What do you say to that? You have to go first.
Yeah, I mean, I can talk about how Big White Wall has addressed that, and it's a real concern. There's a dangerous advice online, and there are people preying on vulnerable people online. So keeping people safe is vital. So the way Big White Wall's addressed that is to keep the community closed, and have a team of clinicians that sit behind the scenes, and all sorts of ways of managing risk. So anywhere you are in Big Whitewall, you can ask a wall guide. So there's a trained professional there 24 hours a day, 7 days a week, and clinicians that sit behind that, and a whole governance structure that sits behind it, because it is crucial.
And I suppose in cancer in particular, I mean, the amount of quackery that is out there, and somebody can come, you need one forceful voice. I mean, I've seen it happen on a chat room page who comes in and goes, guess what? If you eat red Smarties for the next month, you're going to be cured. And they can be very forceful and very persuasive to people who are desperate for some solution. How do you, in this virtual world, this virtual, amazingly powerful world, where how many people did you say you reached with your Twitter chat? It was, I mean, it was astronomical.
2 million
2
people.
million people. 2 million. That is a figure that makes most people's eyes water. If only they could reach 2 million people with any kind of message. How do you ensure that you actually sift out the danger from that?
Well, I think it's important that we have a virtual health centre or a virtual health hub where our healthcare professionals are leading us in the right direction, that it's a secure environment. And one of the reasons why I didn't continue with the tweet chat was because I had concerns that vulnerable people were being exposed to it. And I think that it's vitally important going forward that we are shown what the validated links are and where the accurate information is.
Thank you. Just one final, we've got one last question which we'll take from up there, but just Paul, to you. You have sort of a purview of different countries. How do we measure up when it comes to just embracing something that is new, something that is different? Are we at the top or the bottom of the class?
Well, it's fair to say that generally, if the comparison that is normally made, which is with the US, and we've got some wee way to go. The difference, though, and Beverly made the point earlier on, is that historically what we tried to do was to implement big systems for the whole of the NHS. The NHS, people tend to think of this big organisation, it's like a whale, moves really slowly, changes direction infrequently. No, it is a shoal of fish that looks like a whale, and they go in lots of different directions. And I think technology in that guise then has a number of issues, because if you go for best of breed in that world, interoperability then is incredibly important. And we see that a lot. I think the one thing I would say is, as a business, we're very clear that the data in our system is owned by the organisation. Some other vendors take a different view in terms of sharing that data.
I mean, we could have a whole session, and maybe next year, the ownership of data, which you touched on, is just a fascinating topic. Have you got a little small question? Because I can see the clock running out of seconds. Yes, please do.
Yeah, sure. My name's John. I'm a graduate management trainee here in health informatics. And I suppose it's a slightly self-serving question, but it's a bit about the capacity of leadership to keep up with and adapt to the kind of improvements in technology and the speed that we're going at and all this new information. And I just wondered whether you felt there was kind of a need to bring in new kind of technical skill sets into more senior positions.
Okay, thank you very much indeed. We'll get the young one. I mean, basically, get the young blood in higher up.
We have the leadership in the NHS, so chief exec positions, I've only known of one person who's a technology or an informatics professional who's ended up making it to be a chief exec. And we've got two issues. We need more information, informatics, data, technology skills in the NHS. The National Programme for IT made for many people exiting and moving into other industries. We've got to get that back in. The NHS can't do this if they don't have the skills to do it. But equally, if we start to have people on boards who've got these skills, transformational change, and who make it chief execs, then we're giving a strong signal to technologists like myself that we think this is an important skill set, and it's how we make our NHS future-proof.
Thank you all very much indeed for your excellent questions, and thank you very much for your excellent contributions. I think you've raised a lot of questions which hopefully, fingers crossed, will be pursued in those little pockets that I talked about at the Confederation. Please join with me in thanking our panel this afternoon. Now we're going to head off, but if you're here for the grand fromages, you are in the right place, and we'll be right back. Thank you very much indeed. Thank you.